All right, everybody. Well, it is the top of the hour, and in respect for everyone's time, I think we will go ahead and get started. Seeing a few familiar names there in the attendee list. Welcome to those that I've met, to those that I have not. Thank you so much for joining us today. My name is Jen Bruning. I am the Senior Director of Partner Education for Insight Strategic Partners. We are a senior living GPO. And we're so blessed to have so many connections to wonderful partners out in the senior living industry. One of those amazing partners is Functional Pathways. And so today's presentation will come to you from a couple of just wonderful seasoned professionals and just all around good people. With me is Danny Beveridge and Jen Callahan, again from Functional Pathways, to bring you today's webinar around person-centered responses for individuals living with dementia. And this particular topic, we were chatting a little bit before we started the webinar. This is it's so prevalent in so many people's lives from both a personal and a professional perspective. I was sharing with these ladies that early in my career, when I was a clinical dietitian, one of the areas I was in charge of was our memory care unit in the skilled nursing facility where I was an RD. And you know what, at that point, I'd had some personal experience with dementia. My grandmother had lived with dementia well into her 90s. And so I had kind of a sense of a good way to react and respond to folks and how to interact in a way that worked for them while I could also get the information I needed, get my work done. But nobody at that time ever sat me down to give me any kind of a training around what those interactions could or should look like. And again, it's kind of a combination of things like what does your personality kind of tell you? What do your interactions tell you is the best way to respond to people? But as we said, that's not something that everyone has. But as Danny pointed out, it was such a great quote. You're like, yes, but everyone can learn it. And that's what we're here to do today. And so I don't want to take up any more time talking about the past and things like that. I really want to give the time over to Danny and Jen today. I will be moderating this session. If you do have questions throughout the presentation, please use that Q&A feature. I will be happy to jump in and pass the questions along. We can also take a few questions at the end here, and with a goal of wrapping up by the top of the next hour. So again, thank you all for joining us today. Thank you for the time. We know it's hard to step away from your day-to-day, but I think you're really going to find today's content super relevant. And without further ado, Danny and Jen, please take it away.
Thank you so much, Jen. Like she alluded to, today we're going to talk to you all about our residents who are living with dementia and the ways that we can support them and have increased successful interactions in the most appropriate way. So we're hoping that you guys can take this and really take the information and go back with what you have learned. We will discuss why there is such a focus on antipsychotics in skilled nursing facilities. Also help you all to be able to recognize the behavior and psychological symptoms of dementia, and then some effective programming for those living with dementia. Danny's going to really dive into some real life techniques that we can use. And finally, understand how to help those patients live with the highest quality of life and reduce those negative reactions that are associated with the diagnosis of dementia. So let us dive right in. So why the focus on antipsychotics? Well, as you can see here, our good friends at the OIG, from 2011 to 2019, 80% of Medicare's long-term nursing home residents were prescribed a psychotropic drug. That is a huge number for skilled nursing facilities. And then as you can see right below that, from 2015 to 2019, the reporting with schizophrenia in the MDS and the number of residents who lacked the corresponding schizophrenia diagnosis and Medicare claims increased by 194%. Now, some of you might be like, well, why did it increase? And we're going to talk about that in a little bit, but it has to do with the quality measures and those exclusions and some of the other things that go along with looking at the use of antipsychotics for care. And then finally, very recently, there was an OIG study that said doctors are still not necessarily using their skills to help to identify reasons for the use of antipsychotics, and that we're using this for the benefits of the behavior management for the staff rather than the treatment of the resident. CMS is said as actively reviewing the antipsychotic quality measure with the goal of supporting clinically indicated use while continuing to discourage inappropriate prescribing. So they really are cracking down on this and keeping a much closer eye on it than they probably have in the past. So why is there a concern around these antipsychotics? So a couple of things here. Not only does it increase the risk of death, falls, and infections, but it's also a concern as we are still seeing antipsychotics used as a method of treatment around residents living with dementia. We're treating behaviors, we're treating symptoms. Schizophrenia has an incidence of 1 in 9 of skilled nursing facility residents, 1 in 150 in general population. So those numbers don't really add up. And if you think about the average age of onset for typical schizophrenic diagnosis is somewhere between the later teens and the early 30s, then all of a sudden we started to see folks at nursing home age all of a sudden have a diagnosis of schizophrenia. And also the fact that there's some limitations in FDA approved medications for the treatment of some of those psychiatric symptoms that can be associated with dementia is also a concern. So when you bundle all of those things together, you can see why this has been highlighted, especially more recently. What gets measured gets managed, right? So here are those quality measures. Anything from a short stay standpoint, and just level set, remember short stay is any of those residents that have been in your communities for 100 days or less. So any newly received antipsychotics. So one of the things that we talk about doing to kind of manage this and make sure that we are being accurate is really good medical reconciliation, not just with the hospital pre-admission, post-discharge from the hospital into our communities, but also when we have it and we have the availability to ask, what did their medications look like prior to that hospitalization? Because what do we see a lot of times? Hospitals will take them off of all of their medications or a lot of their medications and then restart the ones that they want them to have. Well, what do we know about some medications? How long does it take to clear their system, right? And that might be about the time that they're coming to us or that they've been with us for maybe a week. And we start to see some of these things that we would typically see an antipsychotic medication used to treat or to control, right? And then as far as the long stay measure goes, remember this is now both an MDS and a claims-based measure. Anything received or a pharmacy or Medicare Part D claim or encounter. And keep in mind too that this can also apply if the resident happens to go outside of your facility at an outpatient visit of some sort and receive an antipsychotic there because it's tracked through their claims and encounters. So when we're talking about the quality measures, we kind of alluded to this a little bit, but that misreporting of residents as having the schizophrenia in the MDS to falsely impact those quality measures. Why? Because the diagnosis of schizophrenia, as well as a few other diagnoses, was and is an exclusion. But we absolutely have to make sure that we have all of the documentation to support if that is a true, right, and real diagnosis to where your facility should be excluded or that resident should be excluded from that quality measure. And we weren't necessarily finding that. So you can't have an inappropriate schizophrenic diagnosis to justify prescribing the antipsychotic drugs. And also, you can't use those diagnoses to just skirt the Medicare safeguards. They're there for a reason, and they're meant to protect our residents and compromise and make sure that we're not compromising residents' care by inappropriately diagnosing the residents with schizophrenia. So it's a twofold process there. And some of the things that we have to do also is make sure that our systematic processes to evaluate each individual's need and whether or not there is a diagnosis, and if that diagnosis does exist, where did it come from? Do we have the accurate coding and documentation that is necessary to back that up? And why is that important? Because there is an audit, and there has been an audit. This is a few years, obviously, that we've been seeing these schizophrenic audits come around. They were a little bit more prevalent a couple of years ago. However, they are still conducting them, and they're conducting the coding in the MDS, and facilities that have those coding inaccuracies that were identified through the audits do see that adjustment to that quality measure star rating. And it's kind of a big deal. Remember, this is reported publicly. This can impact your referrals and some other things that are associated with quality with your community. So there's a little bit of an out right? If you self-identify, or once you get selected for the audit, you kind of mea culpa and say, yes, we want to forego the audit. We understand that we had some coding errors or inaccuracies, that we didn't have the documentation to back up. There is the speak of some lesser action related to that star rating, for not making us go through the process, if you will, of completing the audit. And so, again, just that focus on making sure that if you are indeed coding this, and especially newly coding this, you have some really good documentation that meets all of the required pieces in order to have that and have it be legit for the exclusion. As we discussed, this is the scope of the residents living with dementia. These reasons are not necessarily related to dementia, right? And so some of these things that you see here, we tend to associate, oh, that's just part of that disease. But many of these labels are labeled as a behavior, and should not be considered symptoms of dementia. And it's up to each community to ensure that when antipsychotics are prescribed, they're actually effective in treating the conditions that they're prescribed for. I always use an example here. We had a resident who was receiving a very low dose antipsychotic, and we didn't have, the diagnosis of schizophrenia to exclude us or anything like that. So the community was taking the quality measure, or that, that hit, if you will, and it was for sleep. And I was like, wow, that's such a low dose. What are they, so we looked into it, and it was sleep, and they still weren't sleeping well. And so just having that extra set of eyes, or understanding what we were all supposed to be looking for, who is in charge in your community for looking for these kind of things. If they are indeed getting an antipsychotic, and it's an appropriate antipsychotic, yes, we're going to take the quality measure target for that, the numerator. But is it being impactful and effective for that condition that we are trying to treat? And so that's really important that you have that on both sides. So just diving into this a little bit further, some issues of labeling those symptoms. We need to be careful when we are labeling these things as symptoms of dementia. Many times there's a response or a reaction to someone or something within their environment, or a need that they are seeking to meet, or a discomfort they are seeking to avoid. So things like agitation, aggression, that psychosis, those are labels and behaviors that could be caused by environmental, caregiver things, some sort of thing that we might not have even seen happen. It could have happened 20 minutes ago, and we are still seeing some of the response to that. So when we really think about behaviors or reactions, as Danny and I like to call them, you could actually label those as expressive communication. What is that they are trying to accomplish through this quote unquote reaction, or through this quote unquote behavior? Is there a better way to treat those who are feeling sad, abandoned, lost, terrified, or without a purpose? Is there something that we are missing that we can help with? So how can we as practitioners and community leaders be more impactful in supporting our residents living with dementia? What are we to do? Well, I thought y'all would never ask, because we're going to get into it. So we talk about community opportunities, and I alluded to a little bit of this a couple of slides ago, but making sure that the treatments that they're getting are impactful or effective for the things that they're getting them for. But when you see here, like the medication and diagnosis reconciliation, as soon as possible upon admission. Why? Because like we said, if that person had any changes in their medication while they're in the hospital, we certainly don't want to get dinged for that inaccurately. And really, when we talk about that short stay measure, it's the difference between their admission their admission assessment, and that discharge assessment. They weren't getting on the admission assessment. We coded it on the discharge assessment. That's when you're going to get in that numerator for that quality measure. Some of the other things, and these come straight from CMS, and those are some of these ideas for or possible things that you can do around antipsychotics. Gradual dose reduction programs. Even if you've maybe tried it before, it's okay with trying it again, or trying some different methods, or trying different things every so often, because maybe some of that stuff has changed, or some of the things around it have changed. PRN medications, let's not write those just in case. Just in case kind of makes it sound like it's going to be used as at our convenience, right? And so do they really need it? And if they do really need it, make sure that we have the reasons around it. Make sure that our care plans reflect the causes of behaviors. The more information that we have, and what's going on around that resident, the better we're going to be able to have positive interactions and to treat those things with maybe not pharmaceuticals. Also, programs for persons living with dementia to reduce those behavioral and psychological symptoms. A lot of this has to do with understanding what might be the cause and then what we can do about it. What are the things that we can impact versus things that are out of our control? And then finally, maybe a combination of a little bit of a dose reduction along with programming to really have an impact on those residents. So let's say that we have a behavior change that comes on just kind of a sudden onset, like, wow, that's really not how they normally act. You can see here where we have a sudden onset, we really want to consider some physical or medical causes behind that. Delirium could be a UTI. We always talk about altered mental status with that, but never mark those out. Fever, maybe a low sugar. Is something else going on with their blood work that could be related to this? Dehydration is huge. We know our residents, especially when they have dementia, they may not feel thirsty. They may not seek extra fluids out. Anybody who's on any sort of change of diet or change of liquid may even be at a greater risk for this. Pain, what's going on with this person, and is somebody touching them where they're uncomfortable or they're pain and they don't feel like they can get away from that? That can cause some agitation outside of just dementia and other factors like that. Constipation, medications, anything new, any new timing, any new onset of things that are related for side effects. Medication withdrawal, again, anything that we quit giving them or we gave them at again a different time or a different dose even. And then things like hypoxia, the pulse ox, do we know what kind of oxygen they're getting in? The rest of those vital signs are super important too. Increased heart rate could be an indicator of some of these things. So we really want to take a good look at their physical and medical causes before we just assume that these things are related to their dementia. So if we considered all of the physical medical possibilities that were mentioned on that previous slide, and we determine it's really not a medical concern that we can find, then we have to look at every behavior is a reaction to something that came before. And like I mentioned a little bit earlier, it could be something that you didn't see. It could be something that resident is reacting to that happened 20 minutes ago. It could be somebody that looks like you, and they associate your physical look with somebody who maybe what they assumed wasn't nice to them earlier. So really having that information and being like a detective, diving into maybe what the root cause is, documentation of what time of day does the patient have behaviors or reactions, who was around, what was happening in that person's environment that was going on, who was present, did somebody come up to the resident, were they startled, did something else happen that we didn't see or that we could make as part of our investigation, if you will. Or is the patient trying to communicate something? Is there a need that's not being met? Is there a discomfort that they're trying to escape? We're either seeking pleasure, seeking things that we need, or avoiding pain, avoiding discomfort. So we really have to think in that circle of thought when we're trying to identify the reasons behind these. So we can pretty much break it down into three categories of things that may cause some reactions or behaviors. Patient detriments, something happened, right? Caregiver detriments, determinants, somebody approached or somebody did something that it was their perception of it. Or again, something in that resident's environment could cause. All three of these factors can contribute to these behavioral or reactive symptoms. Really, when someone is having something like this, even if we can't figure out why, if there's a negative reaction, we want a new place with a new person doing something different. So really taking all three of those factors and changing them and removing them from that situation. So when we look at the things that we can control versus the things that we can't control, we cannot control the gender of the resident, right? We can't control their marital status or some of the other things that just make them who they are. But we can control things like, or at least have an idea about those comorbidities, those conditions, physiological needs, existential needs. Again, that comfort thing is huge with these residents. How are they sleeping? So things that are determined by the resident. From a caregiver determinant, the things that we can't necessarily impact the caregiver's personality, right? The quality of what's happened to them or somebody that looks like them in the past. education, their personality or temperament. What we can control, caregiver burnout, it's a lot sometimes. And it's a lot, especially when you don't have wins every day of taking care of residents and having maybe successful interactions. So really helping to control that and counteract that. Um, Depression amongst our caregivers, it's real. Having day after day of people not necessarily having a positive interaction, it happens. So any kind of those skill levels or the education that we can provide to control or contain or decrease the negative reactions are going to help. And then finally, those environmentals. We can't really control staff mix or the staffing level or the staffing ability. But what can we control? We talk about things like lighting, outside stim, things like noises, music. Do we have music going really loud while we are trying to feed residents living with dementia in a dining room? Some of the residents probably love it. It may be too much for those folks. And so really making sure that we are taking all those things into consideration when we are having these sort of things go on. And with that, in order to take an even deeper dive, Danny Beveridge.
Thank you very much, Jen. So as Jen was talking about all those factors that are fixed and those that we might be able to change, we want to put our detective hat on. We want to dig a little bit deeper and figure out if a resident's having one of those negative reactions, what could be the factors involved? We talked a little bit already about the environment, right? The environment could be having the right amount of light, the right amount of noise, clutter, things in the environment that are cueing me to do things. If I see an open bathroom door, I might want to go to the bathroom all the time. We have to make sure that as we're trying to figure out what might be the cause, we're digging deeper into that. We also want to look into the task itself. When I am looking at what we're asking our residents to do, we might be causing the reaction from the frustration of not being able to understand. Are we giving them the right amount of cues? Do we look at simplifying the tasks that need to be involved? Are we making sure they have enough time to respond? By the time we're in middle to late stages of dementia, we need 30 to 60 seconds to process. Have you ever sat in silence, for example, after asking someone to stand up for 30 seconds? It's the longest 30 seconds of your life. So looking at giving them enough time to be actually taking that information and respond is going to be key. But one of the biggest areas that we have an influence over is the approach that each and every single one of us use as a caregiver. And that's where we're going to spend the majority of our time here at the end of our presentation talking about. So I am a certified coach and trainer for Teepa Snow and her positive approach to care. For those of you not familiar with Teepa, she's an occupational therapist by background with many, many years of experience in dementia care and is seen as a world leader in looking at how we build our skill set and how we interact with those living with dementia. Not only do we have to be a detective when we're trying to figure out the cause of what we might be seeing from these reactions, but we also have to make sure that we're not being a judge. People aren't doing things on purpose. They're not trying to make our life difficult, although everyone does bring their own personality to all of these situations. We have to realize that for many of those living with dementia, they are using what they have left from a vocabulary perspective, from ability to understand perspective, to communicate their wants, their needs, their fears, their desires. Those of us that have these typical aging brains, we're going to be the ones that are going to have to be really flexible. We're going to have to be able to really pay attention, not only to words, but to facial features, to ways we're communicating with our body, to the environment, to be able to look at how we're influencing the outcome of that interaction. And from that, we're going to be very specific on how we approach our residents, how we get their attention, how we cue them. And we're going to use our approach as a screening tool. That is going to be able to tell us things that we need to know about the resident to be able to have that good interaction. How many words are they able to use? What types of cues might they need? So what might this look like? I'm sure all of us in our communities have that caregiver that we think of, that we're like, they're just really good at this. People say that about Teepa all the time. Teepa's just a natural. She just has this skill set. She's just able to do this. But what we don't realize is that it's very intentional. It's a very specific skill set that anybody can learn if they just practice. But there's a difference between having a skill set and having knowledge. Many of our dementia education programs only focus on knowledge. They focus on days like today when you come and watch a PowerPoint and you learn facts. I don't know about you, but I've never become better at shooting a basketball by learning more facts about basketball, right? I have to actually go out and practice shooting hoops with my 10-year-old who still beats me at horse, by the way. So today we're going to talk about TIPA's process, which includes something called the positive physical approach. I'm going to take you step by step by what that looks like. We're going to talk about a specific technique called hand under hand that allows us to do activities with a resident versus to a resident. We're going to talk about how we use our cueing in what order to be able to provide that supportive communication in a way that's going to improve that relationship between the caregivers and the resident. Because all the care that we provide is a partnership. There's two people that are involved in the care. It's us as caregivers, and it's that resident. And what's most important in every one of those situations is the relationship between the two. So making sure that that relationship stays strong is how we're going to get those good outcomes. So let's talk about these very simple steps that are part of the positive physical approach. How do I get into an interaction with a resident? The first thing I'm going to do when I interact with someone is to get their attention. There's 3 different ways you can get someone's attention, right? You guys think of what they might be? I'm going to give you a second to think about it. You might see me. You might hear me. Hey, Jen. Or I might tap. I might use touch to get your attention. There's a very specific order that you want to do this in. I want you to close your eyes for a second, and I want to imagine that you're in a haunted house. All right? What makes a haunted house scary? Think about the things that happen while you're walking through it. Things are jumping out at you when you didn't know they were there. Things like puffs of air might be touching you when you didn't know those puffs of air were coming. There's loud noises that you don't know what direction they're coming from. I sometimes like to think of living with dementia as living in a haunted house. We have to, as caregivers, try to make that haunted house a calm environment. And we need to think about what is something that I would want if someone were getting my attention. I don't know about you guys, but I don't like it when people just come up and touch me before I even know they're there. In fact, I'm going to make sure that's last on the list. That's going to be number 3. What do you guys think about visual fields, being able to see you or being able to hear you first? Remember those loud noises that go off? Those can be startling too. So the first thing we're going to do is get in someone's line of vision. I know that seems silly and seems maybe a little bit basic to talk about, but I want you to understand the visual field awareness of those living with dementia. When we are 25 years old, we all have 180 degrees of peripheral field vision awareness. So I can pay attention, my brain can pay attention to all the things that are happening in my environment. With typical aging, that shrinks in 15 to 20 degrees on each side. By the time I'm in the early stages of dementia, it's like living with wearing binoculars. I want everyone on this call to put binoculars on over your eyes. I want you to look around in your environment, and I want you to see what you notice. If you're adventurous, I encourage you to get up and walk across the room and come back. What most people tell me when I ask them that question is, what do I notice? It's what's right in front of me. So to get in that visual field awareness, I have to be right in front of that resident. Think about what that means for our residents that are in wheelchairs, where they may have a stooped posture, right? I may have to get a little bit lower to get in their field of vision. What happens if I don't get right there in their field of vision? What if I'm standing outside of their field of vision and I say hello? Right? We're back in that haunted house and you startled me. Part of our job as caregivers is to help keep our residents calm. There's a deep part of your brain, something called the amygdala. That amygdala is what controls our fight, flight, and fright response. Also freeze, the 4 Fs. When we kick that response off by doing something like unintentionally startling a resident, cortisol and adrenaline start going all throughout our body. And it kicks off this awareness of, I need to protect myself, either by fleeing, freezing, fighting. When we do that, it can circulate for 20 to 30 minutes in a resident's body. That's a long time to live in a place of being slightly fearful. I come in, I have a bad interaction with Jen, and I'm a smart caregiver, so I know to walk away. And then I have my coworker walk in right after me, and now suddenly we're in an altercation. And they have no idea what caused it, and it could have been from me 20 minutes earlier. I bet you guys never thought I would talk about 5 minutes about coming into someone's center field of vision. So we're going to get in the center of their vision when we start to approach, right? And I'm going to stop about 6 feet out. So that is, if I put my hands out and you put your hands out, our fingertips touch, that's about 6 feet. Now, why am I stopping so far away? It's the difference between public and personal space. What happens when someone comes into your personal space too fast? Does that kick off your amygdala, or does that keep you calm? I want to start off by coming into that public space, and I'm going to wait to get permission to step into that personal space. I'm going to wait to get permission to touch. This is how we're using our approach to help us analyze, is this resident ready for more interaction? I'm also going to think about how I stand. There's something in TIPA's world that we call confrontational versus supportive stance. So when I'm standing in front of someone, if we're getting into a conflict, how do I stand, right? I square myself off. There is nowhere for you to go because I am confronting you. Where if when I approach someone, I just drop a shoulder back, it becomes much more supportive. They have a visual field awareness now that they can leave this conversation, and it doesn't feel as confrontational. So once I approach in that visual field range, public distance away, I'm going to say hello, and I'm going to get permission to touch. And how am I going to do that? In a way that's been culturally acceptable in the United States for as long as the United States has existed. And I'm going to offer my hand in a handshake. When I say hello in my supportive stance, I'm going to put my hand up here by my face. Hey, Jen, it's Danny. Now, why am I going to put my hand up here? I want to extend my hand in a handshake. Do you guys remember what I told you about visual fields? Visual fields are very much like cameras on Zoom calls. When I extend my hand to shake your hand, does anyone see it right now? If you do, you're better than me, right? It's here. It's close to the resident's face, but it's not in their visual field awareness. They're not going to be aware I'm trying to get that permission to touch. Now watch my hand. Hey, Jen, it's Danny. The resident can track my hand all the way to the point that they come in to shake it. Once they shake their hand, I'm going to get into something magical called the hand under hand position. So this is another TIPA Snow technique, again, that allows you to do things with a resident versus to a resident. Let me show you what hand under hand looks like. Welcome to the chat, my lovely son's glove. This is our resident's hand. I am the caregiver, and I'm going to come into handshake. When I do this, I'm going to butterfly our hands up. My thumb and my first finger are around their thumb. I'm going to put my hand flat as a caregiver. And then I'm going to be here to support that resident's upper extremity. Then what I can do is keep my strength fingers. My strength fingers are my 4th and 5th fingers around that resident's wrist. That's going to allow me to guide their hand. But it keeps my skill fingers free. My thumb and my first 2 fingers. This is going to allow me to help the resident. So I can put a spoon in my hand and allow that resident's hand to come to their mouth while I'm helping them eat. What's the difference between that? I want you to close your eyes for a second and imagine that I am poking you in the mouth with a spoon. I love Jen's face when I do this on camera. right? How comfortable does that feel just in imagining it? Now I want you to imagine your hand coming to your own mouth. What have we all done since we were newborn babies, right? My hand comes to my mouth opens. If you have a resident who is struggling with intake, who's not able to eat enough food, this is a great way to encourage intake by allow that resident to feel like they're a part of eating. You can also use this technique to help with things like dressing, putting clothes on, unbuckling belts, combing hair. All of it allows that resident to be able to participate. I'm still analyzing my resident, though. I'm using my approach to tell me what happens next. And when I'm shaking their hand and getting the hand under hand, I'm noticing touch tolerance. Now I know, are they okay with me getting closer? Because they said, yes, I'll shake your hand. And now I know, are they okay with touching? I can move on to that next activity because they've given me that permission. Once I'm in close, I can do things like moving into their supportive side. Ideally, hand under hand is always done on the dominant side. So I may come in and shake hands with my right hand, but if you're left-handed, I'm going to be sneaky and I'm going to switch over to the left side for that supportive conversation because eating, brushing teeth are going to make a lot more sense with my dominant hand. Then I'm going to make sure that I'm always staying at that resident's eye level. Part of keeping residents' brain calm is making sure they feel safe. Standing over top of residents could be seen as a dominant posture. And we want to make sure that we are on the same level as them because we are part of that partnership. So as part of our slides, we give you the steps to hand under hand. Not only can we use it as part of any ADL activity or IADL activity, but we can also use it to help guide our residents who are ambulatory, who maybe need some redirection. Our hands are like the rudder of the ship. So I can use this hand under hand posture to be able to guide someone to walk within an environment. I might use it to help them reach back for a chair to sit down or to reach up for a walker once they're standing. By utilizing that hand as a rudder, we're going to be able to guide them throughout that environment. So as we talk through this approach now, we have our permission to come in, to interact, to touch. So we've talked about how visual, verbal, and then physical touch is the order of cues. But now we're going to have to move into actually asking them to do a task, right? So we might ask them to do that shower that they've been refusing or trying to get them to get out of bed that they don't want to do. How do we make sure that we do that? We have to look at our next steps. We want to make sure that we are connecting emotionally with residents. If we don't take that minute to connect, it can be hard to get into those intimate personal activities. Then we should look at that resident spiritually and individually. What is it that their needs are? What are those unmet needs that we want to try to help them? Are they lost? Are they lonely? We have to take all of that into consideration while we're interacting with our resident. If we have a resident that we're trying to connect with emotionally and stakes start raising and become a little bit more aggressive or agitated, there's some steps you can consider based on each stage of dementia. Early in the stages of dementia, it can be very difficult dealing with frustrations that you may not have the insight to realize you're having issues with those certain circumstances. A simple apology can go a long way. I'm so sorry you're feeling this way. I'm so sorry this happened to you. We still want to keep the relationship, right? We don't want to lie, but we want to make sure that we're validating what is occurring to them because nothing is worse than not being heard. And then offering apologies that are meaningful, but not a lie to those residents. In the middle stages of dementia, we might consider reflecting their words back to them with the same emotion they're bringing to us. And then we want to listen for any information that we can fully gather. In the middle stages of dementia, we're starting to lose a lot of vocabulary and a lot of words. We have to look at their posture, their facial expressions. We have to be wondering what is it that they could be trying to communicate so we can narrow to be able to meet that need. A really common concern that happens in early and middle stages of dementia is the I want to go home. And a lot of times our caregivers don't know how to respond to that question. And I always give the advice that everyone wants to be heard. So if I have someone coming to me with that, I want to go home, I need to go home, I'm going to respond back with that same emotion so they know I've heard them. You want to go home. I take it as serious as they take it. I turn my body and I stand next to them so we're on the same team while we try to figure out what this emotional issue is that we're trying to figure out. Later in the stages of dementia, you may want to consider looking at posture, at movement. At this point, most words are gone. So the way the residents are communicating are usually through gestures, through vocalizations. We're going to have to try to dig deeper and look for the need underneath all those actions that are happening. When we actually get to the point that now we need to do something, there's a lot of different things to consider to get that resident to want to do the agenda that we think needs to be done. Again, early on in the stages of dementia, we start losing 1 out of every 4 words. And what do we as caregivers like to do for residents to help them? Talk, right? If I see someone struggling, I try to talk, I try to give them more words. And what we have to realize is if we're missing 1 out of every 4 words, we might be escalating a situation. We might be causing more confusion. We might be making it more challenging. Instead of offering more words, we may want to consider simplifying the words. So instead of saying, breakfast smells so wonderful today, I bet you're hungry, we should go down to the lunchroom at 12, I might say, hungry? Lunch? I might include things like visual cues along with my verbal cues, knowing that they're starting to lose words. We might want to consider how we use that hand under hand so we can do things with that resident. My dad passed away a few years ago after 8 long years of living with dementia. And in the end of the stages, when my sister and I were still helping, as you can imagine, he was not very comfortable when we undressed him and got him in the shower. But what helped was us doing hand under hand, especially with belt buckles and buttons on his pants, because it felt like his hand was coming to his pants. His hand was undoing the belt buckle. Now, was it successful every time? No. But we had a large toolkit of knowing all these different things to consider that we could try different things to see what would work each time. We may want to consider offering concrete choices. I know Jen Bruning started the conversations talking about her history as a dietitian and being able to find out things like food preferences. When we get to middle and late stages, instead of saying things like, what's your favorite food? We may want to change it to, would you like the steak or chicken? Simple, concrete choices. In fact, I'll give you a magical statement that you can consider incorporating. It's called, or something else. Many times our residents have a need that we're trying to figure out. And if I only give them 2 words, if I only say, Jen, are you hungry or thirsty? What does she tell me if she's tired? She doesn't have the word for it. She might just parrot back the last word I told her, which means I didn't identify the need. She's probably going to get more cranky because now I'm trying to get her to do something that doesn't mean what she's trying to tell me. Instead, I may say something like, are you hungry or something else? It's my way to give 2 choices to narrow it down that we can try to get to what it is that they need. Because frequently, if it's or something else, you'll get that no, 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 until you get to yes. So that might be something to consider. You might consider asking for residents' help. You'll notice I didn't say offer to help them, especially in the early stages of dementia, where insight into deficits might be affected. If I try to say that a resident needs help getting showered, it may cause issues if they don't think they need any help. But if I ask for their help, if I say something like, we just had the water temperature changed in the facility, and I want to make sure the water temperature is right. Can you take a shower and tell me how the water temperature is right now? They might be more willing to go in and take that shower if they haven't the insight to realize that they haven't taken one in 3 days. We might just ask the person to try. I know you don't want to do this. Could we just try it? If it doesn't work, okay, we'll move on to something else. I might even try to simplify things all the way down just to single steps. So instead of talking about getting up, getting ready, brushing teeth, going to breakfast, I may just say, hey, let's go to the bathroom. And if that's too much, I may start with, lean forward to stand up. Breaking it down into smaller and smaller pieces may be key. When we're trying to communicate with those living with dementia, we should consider how we can keep it simple. We already talked about losing 1 out of 4 words. I once had a therapist that I was working with who was asking for some help with residents that were living with dementia. And she told me that her resident was refusing therapy every day and she didn't know what to do. What can I get her to do to participate? And I said, well, tell me how that interaction goes. What do you say when you walk in the room? And she said, I asked them, are you ready for therapy? They said, never ask that question. You don't want to ask any questions that you want that they can say no to, that you don't want them to say no to. So instead of asking them if they're ready, maybe you could give them a choice. Would you like to come now or in 15 minutes? Or maybe you could even phrase it as a statement. It's time for therapy. There's a lot of different ways, and how we choose our words in those interactions can be really, really key. Keep in mind that simple is always better. But not only simple, but we have to slow ourselves down. We have these agendas, right? We're so busy. As a therapist, I have to treat all my patients. I have to get all my documentation done. As an aide, I have to provide care to all those residents in showers and waits. We're going to have to take a minute to wait, to pause, to slow down, to give our residents time to process. I frequently will have caregivers tell me, but Danny, I don't have time to do that. And what I will tell you is that you don't have time for that resident to escalate into an interaction that has turned into someone punching someone else, that has now turned into a larger issue that we're going to have to document and follow up, and now we have to calm them down. If I can take sometimes no more than an extra 30 to 60 seconds, you can be surprised in the difference that you can have. For any communication that we're having with our residents, if what we're trying to do doesn't work, we need to stop, right? Isn't that the definition of insanity? Keep trying the same things over and over again and expect different results. But this is where it's great that we have these typical sapphire brains, as Teepa would say. We have that minute to take a step back and realize that it was nothing more than an uh-oh moment. Uh-oh, something happened. Something happened. Let's go be a detective. Let's figure out different things. Let's think through what might be going on. And let's turn it into aha moments. Let's reapproach. Let's try something slightly different. Let's see if we can get a different outcome. Let's look through all these tips we talked about visual fields, getting permission to touch, looking at how we interact and how we use words to figure out how we can get that better outcome. Simplified into 5 tips for working with people living with dementia. The first thing we need to do is step back and observe. Watch what's happening. Be that detective. Figure out what it is that resident needs. So many times we walk in with our agenda. I need to get them to the shower to get ready. And we don't realize that the resident may be in the middle of their agenda. I might need to help them stop a task. I might need to help them find some water. I have to help them with their agenda first to be able to get to my agenda. If something is occurring, we have to remind ourselves that we want to respond. We do not want to react in the moment. We should be looking at our own tone, our own mannerisms, what our eye contact is telling someone, what our posture is, how am I standing? Am I being confrontational? Am I being supportive? Am I next to the resident? What could be different? We want to make sure that we are being flexible and trying different things. Our toolkit needs to be really, really deep because we have to try different things to see what works. And at the end of the day, we have to realize that the only person that we really control is ourselves. So if something is going wrong, I am going to have to try something different. I need to remove myself from that equation and figure out how I can help influence that conversation in a different way. Because we want to stop doing what doesn't work. We have to be creative. We should bring in more brains, looking at everyone that is an expert in our communities, everyone that's had good interactions, making sure that we're having that brain trust, because there's not one bad idea we can bring to the table to be able to help care for those living with dementia. So now that we understand a little bit more about how approach can affect those negative reactions, let's talk about what programming should look like in our communities. Many times when I have visited different sites over my 26-year career in senior living, the activities that I see happening in the programming for those living with dementia is rest, relaxation, and entertainment. It's recliners in front of movies, listening to music. And we have to realize that programming is probably going to have to be more expansive to really meet those residents' needs and to do things like reduce their risk of falls. If we can engage our residents throughout the day in a way that's meaningful to them, we're going to allow them to sleep more at night, to be able to eat more at meals, to be able to have less negative interactions. And it all comes down to how we structure their day. To me, a program always starts with identifying the stage of dementia. I'd be curious, I'd love to hear from everyone on whether they stage residents' dementia in their communities. And I'll be honest, I've been doing dementia training now for probably 10 years. And the answer 98% of the time is no. If you had cancer, would you want to know if you had stage 1 or stage 4 cancer? Why would you want to know that? Because the treatment is different for each stage. And the same goes for staging with dementia. Staging allows us to have that predictable characteristics of what their cognition may look like, what their visual field awareness is, how many words they're able to use, what's the pacing of how I lay out what there need to be done, what is their motor skill ability, what are they actually able to do physically. By staging, we can set appropriate goals for our resident and most importantly, have appropriate treatment plans and care plans that we're able to meet that resident where they're at. And it also allows us to track disease progression. When speaking with loved ones and family members of those living with dementia, the biggest complaint we hear is the fear. They don't know what's going to happen next. This is a terrifying disease process. If we can help equip them with the tools to understand the progression of this chronic disease, they're going to be able to prepare for each stage, to know what's coming next, to have a better plan. At Functional Pathways, we use TIPA's staging system, which is called the GEMS. If you are interested, I highly encourage you to reach out to TIPA and her positive approach to care team. There's definitely some positives that come from utilizing the GEMS versus other tools. Many of the other tools that exist out there, to give you an idea of some of their names, the Global Deterioration Scale is one. There's Claudia Allen scales is another, which is a number scale. Those scales inherently have negative feelings attached to them, right? Do you want to know where you're at on the deterioration scale? Is a 7 better than a 1? There's innately things that are positive and negative about all of those scales. What's great about the GEMS is it recognizes that each stage has the capability to shine. There's not one gem that is better than another. You might have one that's your favorite, but innately there's not one that is better than another. And by recognizing that these GEM states exist, we're going to be able to provide that positive, supportive environment. We're going to be able to understand where they're living and provide that right support and that right care that's going to let each of those gems shine. And the great part about the GEMS as well is they recognize that all of our abilities are dynamic and change within the moment. You and I will fluctuate what gem we are in a day. The example I use all the time is I have been frequently known to be a diamond when you put me in an airport I've never been before. A diamond is someone who is at mild cognitive impairment, and they live by routines and they don't do well in new situations. I realize that in that situation would not be the time to call me and ask my plans for the weekend because I have to look at exactly where my gate is and know what time it is. I very much become a diamond. And that's helpful because we realize that we have to be a sapphire to help support other gem states. So recognizing where we are to be able to pull ourselves back up to that sapphire state before we interact is key as well. There's lots of different staging tools out there. If you're interested, we include this as a resource. Whether that be using Alzheimer's language, there's developmental age comparisons, there's the Allen Cognitive Scale like we talked about, there's all different scales that exist out there. But what we find is we're all saying the same thing, we're just using different language. The GEMS are a great tool to be able to take that idea of what their deficits are and what their remaining strengths are in a way that frontline care staff can really understand once you get to learn the tools, how to interact with those residents. Another key part, once we have our staging, is looking at what our care plans look like. Are we going above and beyond just sitting in recliners in front of a TV, or bingo for our high-level residents? Bingo is a fantastic activity. But once we're in those middle and late stages of dementia and I start losing my verbal ability and my ability to follow directions, how can I still cognitively challenge my residents? Are we looking at challenging our residents across all domains of wellness? Are we looking at physical activity? How do I get someone to participate in activity if they can't follow direction? I have some really good news for you guys. There's certain things that stay with us all the way through the end stages of dementia. Music, rhythm, poetry, prayer, if that's important to you. All of those stay through our end stages. Incorporating music into our physical activity might be a great way to get someone to want to move. Are we looking at how we challenge them at the highest level? I may not be able to complete a jigsaw puzzle, but maybe if you cut magazine pictures in half, I can match two halves together. Are we still involving our residents in social activities? As a therapy team, we frequently provide group services. And I can't tell you how many times I've heard from therapists that, oh, they can't participate in a group because it's challenging. They have dementia. To me, that sounds like we're trying to isolate, right? Everyone benefits from social activity. We have to figure out how to do it in a way that makes sense for each individual resident. What's the right amount of people with the right amount of noise in the right environment? Looking at how we can really focus on well-being and so forth, no matter, excuse me, what stage of dementia that they're in. Because by doing that, we're going to be able to structure days. Again, we're going to reduce fall risk. We're going to reduce those risky, challenging behaviors because we're going to be able to provide subtle supervision in a way that maybe we weren't able to before. And then we're going to be able to reduce that anxiety and that distress. Because I have great news, guys. Even though it's a chronic progressive disease that doesn't have a cure, dementia can be treated. But it's going to be treated by us having the knowledge first, and then working on our skill set, really focusing on how I interact with those living with dementia. By having a lot of compassion and a lot of flexibility, I'm going to be able to provide that quality of life that helps that resident shine. But it takes our entire team. We have to circle the wagons around our residents living with dementia because the key to their quality of life is us and the relationships we have with them, whether that be your therapy team, your nursing team, your housekeeping, your wellness, their family members. All of us need to be on the same page and understand these types of techniques to be able to get the outcome that we want. And then I'll end today with a quote from Teepa. Dementia doesn't rob someone of their dignity. It's our reaction to them that does. Again, we are the key to the quality of life. How we respond and how we don't react is going to be what makes the difference. Thank you guys for our time today. Here you'll see Jen and I's contact information. If there's any additional information you would like about TEPA, about the positive approach to care or dementia care in general, feel free to reach out to us at our email addresses. And Jen Bruning, I'll hand it back to you.
Amazing, amazing, gals. Thank you so much. I did answer a couple questions in the chat, but just to say it verbally aloud to the entire group, we will be able to share these slides with folks, correct? We get those sent out? Absolutely, yep. We will make sure that those are sent out to all attendees, just so you have that. We had a couple folks say, I'd really like to share this with my staff. And in this last couple of minutes, there were a couple questions that just occurred to me, if I can kind of share those. The first, Danny, you started to hit on a question I'd already written down. And so you partially did address it, but I think for a lot of the leaders on this call, hearing more about how to present to staff the concept that taking that extra 30 to 60 seconds will in fact yield you saved time in the end could be kind of helpful. Have you found that there's certain things you can say to your direct care staff that might help incentivize that kind of begrudging person who doesn't quite believe that going visual, auditory, touch would actually help save them time in the long run?
So I'm a firm believer in show me, don't tell me.
Great.
This is actually something that therapy teams can work on. If we have a resident that is really struggling for whatever reason, I love to find the resident my caregiver is struggling with. Who is it that you're having a problem with right now? And when I can fix that problem for them and it makes their life easier, suddenly they're willing to see the difference between how they approached and how I approached.
Mm-hmm.
A great example of this was recently in one of our communities. We had a resident who was becoming combative when the staff was transferring him with a Sarah Steady lift. So using that Sarah Steady, he became combative, started punching at them. Wasn't going well. They were going to move to a Hoyer, which, as you can imagine, if that he wasn't comfortable in a Sarah Steady, how comfortable he was going to be in that Hoyer, right?
Mm-hmm.
So we had our therapist go in and we evaluated him. And what they figured out is that they needed to slow down how soon they touched him. And they needed to play Frank Sinatra and sing
Wow.
New York, New York.
Wow.
And when we did that for 5 to 10 seconds before they had him stand and move, he sang and danced the whole time.
Wow.
And the minute they saw that, they went, oh, that's what that means for that resident.
Yeah.
So I know that's a really complex way to get to it, but I tend to find if you can truly show them the difference, they'll see the difference. I actually have
Absolutely.
a harder time talking to leadership teams about why they want to invest in the education for their frontline staff to have the skill set.
I see. Yep, that makes sense. Awesome. Thank you so much. That was a lovely story, actually. I love that. And then Jen, one for you that I had written down. And this is just me making sure that I'm following the information because you all know so much more than I do. But going back to kind of the first half of your slides, I sort of worked myself backwards from that point of the modifiable factors and the static factors between the resident, the caregiver, and the environment, and move myself backwards all the way through to the beginning of the slides, which around the schizophrenia statistics and things like that. So please correct me if I do or do not have this correct, that essentially what we are saying there is that when we have an overstimulated resident and an overburdened or burning out staff member who's not able to use the right techniques to address this unmet need, we end up having more of those behaviors that may or may not be linked to that dementia diagnosis. Without these interventions, we can then see an increase in those antipsychotics being used to treat a symptom and not a cause, kind of a behavior and not a root cause. And then over time, that can end up inadvertently or otherwise building the case of something like a schizophrenia diagnosis. Do I have that right? Am I making a leap there? Or is that our story?
Except for the building the case. So those
Okay.
behaviors and stuff do not build the case to schizophrenia.
Okay.
And that's the biggest thing that a lot of people don't realize. You have to have 6 months of documentation of very specific things related to schizophrenia for that diagnosis. No, our whole point in that was that's not building the case. You're using those medications instead of the skills that you could possibly have, or those, the responses instead of reacting. What is the reason behind that? And then digging into that. So no, our whole point with the schizophrenia was don't use that diagnosis as an excuse when there's other things there.
Gotcha. Okay.
And truly in those cases, those antipsychotics are chemical restraints.
Yeah.
We're sedating instead of really trying to meet those resident needs.
And it's federal regs, it's quality measures, it's all those things. So
great. Thank you for clarifying that, because that's just something where I don't have a nursing or therapy background, so I don't have a direct link to the use of those medications so much, except for the understanding that they can be overprescribed, overused, instead of meeting those root needs. So, those are the couple questions I have. We are a couple minutes over the top of the hour. I've broken my promise to the folks who stayed on to listen to our wrap up here. But again, for everybody who's on, we will get you the slides. You have the emails here of the gals from Functional Pathways. You will have mine when we send the slides out. Feel free to reach out with any questions you have. And Danny and Jen, again, thank you so much for your time and expertise today. We really, really appreciate it.
Thank you, Jen.
Thanks everybody so much for having us.
All right. Have a great day, everyone. Bye-bye.
Bye.